Good afternoon, everyone. Thank you for joining us in this webinar, and I will talk about the role of advanced imaging for the diagnosis and risk stratification. I will start with a very simple case, but I think this is illustrative of the controversies around this entity. And it is a 25-year-old male, an athlete with no previous personal or family history. And during a routine sport checkup, some minor ECG abnormalities are described. So he's referred to the cardiology clinic. Echocardiography is performed and a mild LV enlargement is described with mildly reduced ejection fraction of 45%, a normal right ventricle, no valvular heart disease, and a significant hypertrabeculation in the apical and lateral apical segments. So the first possible diagnosis is considered to be an athlete heart. So the patient is recommended to reduce the sport intensity for 6 months, and after that, a complete study. After these 6 months, the Holter, the exercise test, and blood biomarkers are normal, but the CMR shows a severely dilated LV with lower normal ejection fraction of 52%. And a significant hypertrabeculation, fulfilling diagnostic criteria with a non-compacted to compacted ratio of 2.7 and a trabeculated mass of 30%. No late gadolinium enhancement. So at this point, the differential diagnosis remains between an athlete's heart or dilated cardiomyopathy with excessive trabeculation. So we went to study the family. The father was a 55-year-old man, hypertensive with normal cardiac study, and the mother was a 53-year-old woman with no medical history and asymptomatic. Her CMR, however, showed a normal LV dimensions and preserved ejection fraction, but also with significant hypertrabeculation, fulfilling again diagnostic criteria, even though in a lesser extent, with an NC to C ratio of 2.4 and a trabeculated mass of 22%. No late gadolinium enhancement in her images, and again, the differential diagnosis remains familial form of cardiomyopathy with excessive trabeculation. So we went to study the sister. She was a 22-year-old healthy woman, also an athlete, and her CMR showed moderately dilated left ventricle with normal ejection fraction, but again, significant hypertrabeculation, fulfilling diagnostic criteria. No late gadolinium enhancement. So the diagnosis every time seems more certain to be familial dilated cardiomyopathy with excessive trabeculation. So finally, we proceed with genetic testing, and the proben was positive for a truncating variant in titin, which was considered likely pathogenic, and this variant co-segregated adequately. So the final diagnosis was established as a titin-related dilated cardiomyopathy with excessive trabeculation, which could be nevertheless aggravated by intense exercise. In the evolution, the proben remained asymptomatic with no events, with a mildly reduced ejection fraction, and he is on low doses of heart failure therapy medication. Okay, so we will start this review talking about the diagnostic criteria. As you are all well aware, there are many proposed diagnostic criteria, and I would like to remark here that all of them are based on a small series of patients. All of them use more or less arbitrary cutoff points, either a ratio of 2, 2.3, measured at either diastole or systole, and most of them don't have a histopathological background or clinical follow-up. Just a brief summary of the echo diagnostic criteria. We usually measure the relative thickness of the non-compacted to the compacted ratio in a short axis. It can be performed either at end diastole or end systole, and this ratio has to be higher than 2 to be suggestive of non-compaction. We can also measure the number of trabeculations protruding from the LV wall together with the ratio in short axis. With CMR, we have even more proposed diagnostic criteria. We can also measure in a similar way as in the echo, the ratio from the non-compaction, the compacted layer in long axis in CMR and diastole, and here the ratio has to be higher than 2.3. And we can also measure the global burden of trabeculation, that is the global or total trabeculated mass, and we can express it as the percentage of total myocardial mass. We can index it by body surface area, or we can also perform fractal analysis, which is a mathematical algorithm. What I'd like to point out here is that all these criteria are highly inconsistent, as stressed by this very interesting paper, which recruited 700 consecutive patients referred to CMR for any reason. And as you can see, fulfillment of non-compaction criteria was very different across the proposed criteria. What's most important is that even when considering only CMR criteria, which are thought to be more robust, there was a strong inter- and intra-observer variability among the different criteria. And in my opinion, what's the most important is that all of these criteria, both echo and CMR, are only based on morphologic findings of hypertrabeculation, which are not diagnostic of cardiomyopathy per se, but they do not take into account functional parameters such as LV dimension, ejection fraction, or late gadolinium enhancement. All these inconsistencies in the diagnostic criteria leads to highly heterogeneous outcomes reported in the literature. And in one hand, we have some series which suggest this is a benign entity with favorable outcomes, and saying that the degree of hypertrabeculation is not associated with long-term changes in LV dimensions or ejection fraction. Doesn't seem to be associated with cardiovascular events, or fulfillment of non-compaction criteria on top of dilated cardiomyopathy phenotype does not seem to confer a worse prognosis. On the other hand, we have some series saying that this is a dangerous entity associated with adverse outcomes. And on your left side, you can see a large series describing that the prognosis of non-compaction patients is significantly worse than the general population. And what's more concerning on your right-hand side is that some series report that these patients have even a worse prognosis compared to much dilated cardiomyopathy control patients. However, the controversies surrounding this entity go even further as to question whether this is an actual cardiomyopathy or not. As you are all well aware, some forms of acquired and irreversible non-compaction have been described, such as those in pregnant women or athletes. And also, the prevalence of this entity seems to be much higher than expected for a cardiomyopathy, especially when considering CMR criteria, which can be present in up to 15% of the general population. So altogether, this controversy led to an updated definition in 2023, both by an expert consensus and the ESC guidelines, suggesting that non-compaction per se is not a cardiomyopathy, but rather a phenotypic trait that can occur either in isolation or in association with an underlying cardiomyopathy. So probably the most important question here when you face a patient with excessive trabeculation is to decide whether this patient has a physiologic form of trabeculation, that is a benign or isolated hypertrabeculation, or whether it is a pathologic case which is associated with a cardiomyopathy. Several algorithms have been proposed in the literature, which basically suggest a comprehensive patient assessment, focusing not only on the degree of hypertrabeculation, but also in symptoms, family history, ECG abnormalities, advanced imaging parameters such as strain, light gathering enhancement, genetics, and so on. With our group, we published a large multi-center study, and we described that even though the general risk in the overall population of MACE was up to 38%, when you considered individuals with a normal ECG, preserved ejection fraction, no late gathering enhancement, and no family aggregation, this subpopulation had no long-term events at all during a 5-year follow-up, suggesting they probably correspond to this physiologic or benign hypertrabeculation cases reported in the literature, not associated with an underlying cardiomyopathy. On the other hand, patients with abnormalities in any of these mentioned variables had a much higher risk of MACE, suggesting they have a non-compaction cardiomyopathy or cardiomyopathy with excessive trabeculation, however you want to call it, but nevertheless a cardiomyopathy with increased risk of adverse events. Recently, we finished a very large international study where we performed CMR core lab analysis at our institution, and we saw that the independent predictors of MACE were index LV and diastolic volume, LV global longitudinal strain, and the percentage of late gathering enhancement. Again, on your left-hand side, you can see that patients with a non-dilated LV, with non-extensive LG, and with normal GLS had a very low risk of MACE of only 3%, again suggesting they probably correspond to these physiologic cases or cases with a low probability of associated cardiomyopathy, whereas those with functional CMR abnormalities had a much higher risk of events. And what about patients with preserved ejection fraction? Well, traditionally, they have been considered to be cases at low risk, particularly if they don't have also an LGE. However, we performed a sub-analysis of this core, and we saw that a small subpopulation of these a priori low-risk individuals had an actual risk of LV ejection fraction decline over time, which was associated with subsequent increased risk of MACE. In this population, the only predictor of cardiovascular events was left atrial strain. So that patients with preserved ejection fraction and no late gathering enhancement, but with an abnormal left atrial strain, were at an intermediate risk of events, suggesting they probably had a subclinical cardiomyopathy and not a physiologic form of excessive trabeculation. So we proposed a slightly modified classification where patients with either reduced ejection fraction or late gathering enhancement are those that have a high probability of associated cardiomyopathy are at high risk of adverse events. Patients on your right side with preserved ejection fraction, no late gut, and with normal left atrial strain have a very low risk of associated cardiomyopathy and low risk of events. And there's an intermediate category that we called subclinical cardiomyopathy, which have preserved ejection fraction at baseline and no LG, but with an abnormal left atrial strain. As you can see, there's an intermediate risk of adverse events. Altogether, as I previously mentioned, I think that we have to assess the patient with excessive trabeculation in a comprehensive manner and not only focus on the degree or the ratio between the non-compacted and compacted ratio, but take into account all the imaging parameters, including advanced such as strain, LG quantification, but also, of course, symptoms, ECG, family history, and other complementary tests. Okay, now we will move on to prognosis, and as expected, LV ejection fraction is one of the most powerful and consistent predictors of adverse outcomes, and this was very nicely described in this prospective multi-center CMR study, where ejection fraction was found to be an independent predictor of outcomes, which conferred an additional discrimination in risk stratification beyond clinical data. And also in this very large meta-analysis of more than 2,000 patients, those with an ejection fraction below 45% had a significantly increased risk of cardiovascular death. The same can be said about LV volumes, and those patients with dilated left ventricles have a higher risk of adverse events irrespective of ejection fraction, late gathering enhancement, and clinical variables. Again, as expected and in line with other cardiomyopathies, late gathering enhancement was also powerful and consistent predictors of outcomes. I've already mentioned this nice CMR study, but this was confirmed in a large meta-analysis with more than 500 patients, where LGE was found to be a consistent predictor of poor outcomes, including cardiovascular death, heart failure, and also sudden cardiac death. And again, a special emphasis on those patients with preserved ejection fraction and no late gathering enhancement that had no heart cardiac event during long-term follow-up. Talking about our CMR series again, like I said, we found the best prediction model to be this one, including only 3 variables, LV end-diastolic volumes, LV GLS, and the percentage of LG. And this model showed a very good discriminatory ability with a C-statistic of 0.77. And when we divided patients according to that to tertiles of score punctuation, we could see very significant survival differences. And this was confirmed in an independent validation cohort. What about the prognostic role of trabeculation per se? Like I mentioned, most of the scientific community now believes that they don't have a prognostic role on their own beyond the functional underlying phenotype. However, we have some series that say the contrary, such as in this nice article showing that patients with excessive trabeculation starting already from mid or basal segments have a worse prognosis than those with only isolated apical hypertrabeculation, which seems to be a benign finding. Also, in this very large population study where they measured the percentage of trabeculated mass by CT, they found that with increasing degrees of hypertrabeculation, the risk of MACE and death increased progressively. And what about our series? Like I said, we performed a very thorough assessment of noncompaction, including all the proposed diagnostic criteria, and we found that only the percentage of trabeculated mass was an independent predictor of outcomes, which seems obvious because the NC to C ratio only considers the hypertrabeculation in one single segment. When we combined this variable with the previously mentioned functional model, we saw that there was a modest but significant increase in discrimination with an increase in the C-statistic of approximately 2 to 3%, which was nevertheless significant. If we focus on this percentage of trabeculated mass, we found that the best threshold in terms of survival differences was 38%, which conferred an increased adjusted risk over 2.5 of major adverse cardiovascular events. And just note, please, that this is remarkably higher than the suggested diagnostic cutoff of 20%. Like I said, this was confirmed both in the derivation and in the validation cohorts, and patients with higher degrees of trabeculation had a higher risk of events. However, what is the real prognostic role of excessive trabeculation? Is it more important than the underlying phenotype? And we found that no. What matters most is the functional underlying phenotype, like I will show you. What happens in low-risk individuals is that patients with normal LV dimensions, normal LV GLS, and no LG. Well, in these patients, the degree of hypertrabeculation was not associated with different risk of MACE, and both groups exhibited a benign prognosis, suggesting that in an otherwise normal LV, we should not care too much about the degree of hypertrabeculation. And to confirm that, we compared our cohort with a propensity-matched dilated cardiomyopathy cohort, and we saw that basically the outcomes and risk of MACE were exactly comparable, underlying again the importance of the functional phenotype rather than the trabeculation per se. So just to conclude, I'd like to say that excessive trabeculation of the left ventricle remains a controversial and heterogeneous entity, that the proposed diagnostic criteria are inconsistent, and the measurement of the global burden of trabeculation, that is a percentage of trabeculated mass rather than the NC to C ratio, is recommended, and maybe more stringent criteria should be used in clinical practice. A comprehensive patient assessment determines the probability of associated cardiomyopathy. Prognosis seems to be mainly derived from functional parameters such as LV volumes, ejection fraction, or strain, and LGE, and patients without major functional CMR abnormalities exhibit a benign prognosis. And finally, excessive trabeculation per se holds limited independent prognostic value and seems irrelevant in low-risk individuals. Thank you very much for your attention.
Thank you very much, Guilhem. Very great review and great data from your own center. So very interesting, help quite a lot to progress. So I will start some questions, but please do not hesitate to put your questions through the chat in order to have your questions asked here. So I have, of course, a first question about diagnostic criteria, inconsistencies, and very different criteria that were proposed. I have a first question regarding the gold standard. What is the gold standard to be sure that we are dealing with the real disease, the real issue? So what is usually the gold standard that you think the most appropriate one? And regarding the different criteria, what is the feasibility in practice? Because in practice, we see in most centers only the ratio non-compacted and versus compacted, but what is the feasibility of the evaluation of mass trabeculation and so on? And what is your feeling about the most appropriate criteria?
Yeah, thank you for your question. So first of all, I would say that always to perform a CMR, but sometimes the echo, the window is not so accurate. You may mistakenly diagnose a patient and then you perform a CMR and you see that the degree of hypertrabeculation is irrelevant. So that is already something important. And then focusing on CMR criteria, yes, of course, the Peterson criteria, the non-compacted to compacted ratio is the easiest and is the most widely used, but I think it does not capture the global burden of trabeculation. It's very variable among observers. So I would suggest using or measuring the total trabeculated mass, but of course this relies on having the appropriate software. But I think they will come more and more. They will be more and more available with artificial intelligence powered softwares. And now in clinical practice, we try to include both. And again, if you only see trabeculations irrespective of the degree, but this is an otherwise normal left ventricle with normal dimension, no late gut, I would be very cautious to diagnose this individual with a cardiomyopathy. Of course, you have to describe that, but then it remains for the clinician to decide whether the patient has a cardiomyopathy or not, integrating not only the CMR data, but all the clinical and family history and so on.
Jose, do you want to add something about the diagnostic criteria?
Yeah, thank you. I hope that you can listen me now at this moment. So thank you for this opportunity to bring this session, a webinar with all of you. So I would like to ask Guilhem, because you mentioned that the Peterson criteria maybe to measure the ratio between the non-compacted and compacted thickness is inaccurate sometimes and doesn't give us which patients could be a physiological treat rather than a pathological. You mentioned about the quantification of the trabeculated mass, but sometimes it's difficult because we don't have the accurate software. But maybe analyzing, or do you think that maybe also analyzing or visually analyzing the extension of the trabeculate, the mass of trabeculation within the 17 segment model could be also or give us a choice to suspect that maybe this is not a normal myocardium and maybe we should consider that this is pathological as well?
Yeah, totally agree. Yeah, we have to focus not only on the degree or the severity of this trabeculation, but also the extension, like you mentioned. when you see only in the epic, like in the 17th segment trabeculation there, probably this is nothing to worry about. But when you see trabeculation already starting in basal segment or especially affecting the septum, which is quite infrequent, then I would be more worried, and probably this is associated with a higher probability of an underlying cardiomyopathy. So the semi-quantitative approach, I think, is reasonable. And besides giving the Peterson ratio, if you want, you can give also the extension, the number of segments, for example, affected, or something similar.
And just before going to the chat, that there are two questions, a very quick one, because I know that you have the data as well. So you mentioned that around 20% of the trabeculated mass, as Jacquier stated in the paper, but in your thresholds here, maybe could be even higher, like 38% of trabeculated mass could also add prognostic information. Do you know how many healthy individuals, or do you have any idea, because I know that you compared with the UK Biobank as well, do you have how many idea about how many normal individuals can reach these thresholds as well?
Yeah, so we had access to the UK Biobank data, and it was a healthy population, and no patient at all had a trabeculation in the percentage mass above 38%. So I think this is a very specific criteria. Probably we have a very high risk population because it's only patients referred from referral centers. But yeah, again, I think that using more stringent criteria would probably help us describing the real prognostic importance of trabeculation, because especially with CMR, I think we're using too soft criteria.
Good.
Thank you. We have additional questions, of course, in mind regarding the prognosis, especially, and so on. I propose to continue with the second talk, and at the end, we will be able to continue the common discussion if you want. So,
Good.
Javier, if you want to share your screen for the second talk, which is more about genetics, I think.
Can you see my screen?
Yes.
Yes. Okay. Well, thank you very much for inviting me to discuss about the genetic of this controversial entity, because I think there is difficult sometimes if we don't know the diagnosis of one patient. We don't know if the patient is healthy or has a disease. Sometimes to looking for the genetic substrate of this patient, it's difficult because we don't know what are looking for. So I'm going to start with 4 cases to explain this difficulty between a normal patient or a patient with a disease. For example, in this first case, I show you a patient of 57 years old. It's a patient with any important medical history previously of come to our unit. And if you know, it's a normal control, because for different studies of our unit, sometimes we use doctors or normal patients. So have no family history of the disease, the physical exam is normal, we have not any alteration. And if you see the MRI of this patient, you can see some trabeculation in the left ventricle, but all the other things of the MRI, it's normal. It's normal, the volumes, it's normal, the function, all the things are very normal. And this is other similar case of the previous case, but the difference is that the previous case is a sedentary patient, and this is a very sportive patient. And you can see perhaps more trabeculation in the left ventricle, but the rest of the exam is normal. It's normal, no have history previous on his family, of any cardiomyopathy. The physical exam is normal. The ECG or the other tests are normal. You can say this is normal, not is normal, is a patient with a disease, or is the first stage of a disease. You can say it's very difficult to say that in these cases. But I show you this third case. In this case, the patient has symptoms because the patient is a woman with recurrent episodes of syncopes. But when we examine the patient, it's anything important. But the ECG, you can see a bradycardia, sinus bradycardia, like you see in this ECG. And we did in this patient an echocardiogram, and you can see the same of the other previous patient. You can see an state trabeculation of the left ventricle, but in a Holter, you can see a sinusal dysfunction. So you can, in this patient, different of the previous patient, you have symptoms, you have alteration or rhythm abnormalities, and this you can find this excess of trabeculation. And when we asked to this patient for the other members of his family, you can see other brothers and sisters and other members have bradycardia necessary to put a marcapass or other system of for treat the bradycardia. And when we do a genetic test, we can find this mutation in this gene. So it could resegregate with the disease in the family. Now you can find symptoms. You can find alteration in the test, and you can find alteration in the genetic test. And this is the last case where you can see a very, very important trabeculation of practically the total of the left ventricle. And only if you see that, you see that this is not normal. And when you ask for the other members of the family, the patients say that have congenital heart disease in other members, and the patient have defects in the atrial septal of the ventricle. You can see trabeculation, hypertrabeculation, but you can find other things in the heart of this patient. So in all the cases, you can see this excessive trabeculation, but it's possible you can say in the first case and the second case, consider it like normal, but in the third and the fourth cases, you can see this is not normal because you have trabeculation with more things. And you can find different genetic traits or findings in the third and fourth cases, but not in the previous. Or perhaps because you are doing a genetic test different, because if we are looking for the genetic traits in the first and the second case, it's possible you need to looking for other things in the DNA of this patient that is different about you are looking for in the third and in the fourth cases. And what is the difference? I think in the previously talk, my colleague about because the difference between a patient with a cardiomyopathy and not only a normal phenotype, like it's possible you can find a genetic substrate, but similar like the color of the eyes or the height or the body structure of one patient. So I think the genetics in these cases of excessive trabeculation, it's important to find it because you have a mutation, a pathogenic or probably pathogenic variant. You have not a normal protein, and if you have not a normal protein, it's probably this protein the structure of the function is altered, and the function for the protein not doing well. So you have a problem in this patient, but not the penetrance is different between the different mutation. It's sometimes the patient have no disease, but have a problem with the function of that protein. So it's a risk for the patient to develop a disease. So sometimes I think in these cases, if you find a mutation or a variant, sometimes it's easier to conclude that the patient have a problem that is different if you don't find anything when you analyze the DNA of this patient. No? I think in different cases, we are talking about the percentage of the cases we can find a mutation and what not. And having a mutation is not always a cause of the disease. And how is the genetics of excessive trabeculation? It's very similar of other cardiomyopathies, because you can find patients or families with, when you can find a pattern of the disease very clear, and other cases, like you can see this, you can find only one patient with trabeculation, excessive trabeculation, with a disease, because it's possible you can find a cardiomyopathy with dysfunction of the left ventricle, with a scar, with other findings, but you cannot find other members of the family with the same disease. And why is this? It is because the genetics is very variable. You can find patients with mutation in genes very important for the function of a normal cell. You can see lamina, you can see RMB20, you can see different mutation and with high penetrance. And if you have this mutation, it's very, very close you have a disease. But you can find other genes, other variants in other genes that the penetrance is not higher. You can find the mutation and you need other things to develop the diseases. This is clear, for example, for truncating variants in TTIN, for example, where you can sometimes you need a chemotherapy or an tachycardiomyopathy, or you need overlap of liquid like pregnancy or other inflammatory disease to develop the disease. No? So you have this kind of pattern of inheritance in the family. And sometimes we cannot find a good explication for that, because this is similar with variants of, for example, in vinculin, where you can find loss of function variants of this gene, and you cannot find other factors to explain the expression of that gene. So this is sometimes very, very difficult. And sometimes you can find sporadic cases. And these sporadic cases, sometimes we can find that the cause of this disease is not a genetic cause. But if we assume that is a genetic cause, sometimes it's because you can have the normal mutation, but only in somatic cells, not in all the germinal cells. Or, for example, because you are using a technique for detect the genetic threat or the genetic cause, that it's not the technique you must use to find this the genetic traits of this patient. Why, for example, of that? I put the 4 case. You can find a patient with an excessive trabeculation with a congenital heart disease. So in these cases, sometimes when you find defects in the muscle, defects in the veins or in the arteries, or sometimes you can find defects in other parts of the body, if you use a panel test, for example, to looking for a punctual mutation, you don't find anything, because sometimes the defects are bigger in the chromosomes, so you can find other kind of genetic tests, like, for example, arrays, microarrays, or other techniques. So you can find that for this. There are different kind of studies to looking for the different defects of excessive triangulation. If you say the different alteration in the excessive triangulation, you can find the typical mutation you can find in other cardiomyopathies, like indels, like missing mutation, transversion, transition, etc. of this disease. But sometimes we find other defects like aberration, like inversion, deletion, higher defection that we cannot find it with normal tests. No? And if we have to detect a phenotype like excessive triangulation, but in a healthy person, that you cannot find other things in the family, sometimes you cannot use a genetic test, usual genetic tests like panel, exome, etc. You can find the snippers are associated with the disease. You can find, for example, in this study of the Biobank of England, where you can find different snippers along all the genome are associated with you have more this SNP, you can more probably to develop the disease, and you can find an heritability of 20% in these families where you cannot find a mutation, a variant, a pathogenic variant, but you can find these polymorphic factors of risk to develop the disease. So if we study the population of patients with the traditional series of no compactation or with an excessive triangulation, we see that we have not specific genes for no compactation or excessive triangulation and different for example, the hypertrophic or the dilated cardiomyopathy. And the genes are the same. With an exception that is the tafazine that cause, like you say, a syndrome, a disease like is the Barth syndrome. And the model of Huntington is depending on the different genes. There is an overlapping with the different and other cardiomyopathies, and you can find all the kind of proteins altered for these genes. The most frequently are genes related with sarcomer genes like in BCPC, the heavy chain of the myosin, you can see, and it's less, for example, for other genes like mitochondrial genes, muscle genes, etc. And in the cases, in these series, you can find in 50% of cases, you cannot find any mutation in any genes, but you can sometimes you can find hereditably the disease. You can find the father, the grandmother, etc. have the disease, but you cannot find anything. And in the other case, the different genes are related. So this series is similar to the dilated cardiomyopathies, and when you catch other series, you can find the genes are similar to the hypertrophic cardiomyopathies, but it's in general in between these two diseases. This is the same with 63% of unknown genetic background, but the other genes you can find this, and sometimes you can find other complex disease, genome disease, because you can find double mutation or you can find great defects of the DNA in this patient. So if I told you this, you can say, well, you have not a different genetic background in the no excessive triangulation from other cardiomyopathies. So you have not said that the genetic is a tool to say that it's a different entity. But if you don't see the genes and see the kind of the variant, you can see some difference, because if you say here the difference between dilated and no compactation or no compactation only, you can see there are some kinds of variants like variants like truncated variants in the heavy change or in PRDM16 that you cannot find this kind of variant in the other cardiomyopathies like dilated, restrictive, or other kinds. So you don't have different genes, but you have different kind of variants in the same genes. So you can find this kind, for example, in actina, in PLMD, in the heavy change, that you are only associated with non-compactation or with an excessive trabeculation, but not with hypertrophic, dilated, or other. Or the same, for example, when you find an enriched for the cases of truncal variants in this and others. And sometimes you can find this variant, not only the kind of variant, you can find this variant in a specific loci in the gene. You can find this variant in the head, or for example, in this part of the rod of the heavy change, where you can, if you have a mutation in this region, in this area, it's probably you develop a excessive trabeculation that if you have the same variant but in other parts of the gene. So you have not a specific gene, but there are specific regions associated with this disease. The other important point is the association between the different variants and the different genes with the develop or more aggressive or minor disease. This is difficult in excessive trabeculation, but it's difficult to diagnose the patient in healthy or with a disease. But we have some correlation. For example, when we study the genetics of the children and of the adults, we can find different, because sometimes the children, we can find more defects, chromosome defects, that it's more complex defects in the DNA than, for example, in adults. So the children are more different from the usual findings of the genetics of cardiomyopathies. And we can find more mitochondrial disease, more sometimes genes or defects in genes related with muscle disease that we can find in adults. And if you have more defects in the DNA, in general, the finding of adverse cardiac events is higher. You can see here, when you have cardiomyopathy genes that is you can find in adults, you have minor events than if you have mutations or variants in this other kind of defects. So the most frequent, I think, the cause of the genetic non-compactation in adults are very similar, like other cardiomyopathies, but we have mutation with minor low risk of adverse event that, for example, in children with rare X-linker or defects in chromosome or other case. And you know that the non-compactation during a lot of years are talking about the relation with the muscle disease, with the neurological disorders. And when we find this kind of mutation of variant in this patient, the patient have a worse prognosis. But it's not clear if this worse prognosis is related with the disease or with the problems that you can find in the pulmonary system or in other parts of the body that related clearly with the variant or with the findings in the heart disease. So this is today it's not very clear. So you know this is difficult. Sometimes find this genetic background, and when we need to do a genetic test in patient that we think is have a disease. Well, I think we need to change that when you use a technique or a genetic test, this is a complementary test like the chest RX test or other tests you can use in cardiology. So if you need it, you do it. So, and sometimes when you find or you have a diagnosis of excessive trabeculation, I think if you use the guideline, the last guidelines of the group of the ESC, you can find you have not a diagnosis. You have only and speculation a phenotype. And this phenotype is not the surname of the disease. And you need to find the background genetic to know the future of this patient and to have a good assessment and genetic counseling or a medical counseling to do the aspect. So if you have a suspect of the patient have a disease, I think you need to do a genetic test. So when to RNS? When you suspect this suspicion. And I think in these cases, we can use the study of Villan-Casas that you can find if you find dilatation, if you have a family history of the disease, you have arrhythmias, you have some, if you suspect a disease, you can to do a genetic test in the patient. And to conclude my presentation, I think to say that the genetic of the excessive trabeculation, I think, is similar in the genes to other cardiomyopathies, but in this entity, you can find different or specific variants or in specific regions where you can find not associated with trabeculation. And exists a little relation in the genetics and the clinical into children and adults with different prognosis. Depends of the different variant you can find. And the genetic test, I think you should be performing if you suspect a cardiomyopathy. And this is all I want to tell you.
Thank you, Javier. Thank you for this great review about genetics. Indeed, in my practice, I perform genetic testing quite often when there is a very high suspicion of left ventricular non-compaction, whatever systolic dysfunction. And we have published in the French cohort, coordinated by Gilbert Habib, we observed a yield of genetic testing, which was 40% in our cohort, in the French cohort, so not so bad regarding this. And as you said, genes are usually related to the spectrum of HCM and DCM, and in our cohort, the most frequent gene was chitin, so the spectrum was more close to DCM in the French cohort. And as you said, there are some phenotype-genotype correlations. There are few, but tafazine is one, usually in very young people. You also mentioned HCN4 gene, which is associated with sinus bradycardia. That is quite particular, not often seen with other cardiomyopathies, I would say, in the practice. And also in the French cohort, we observed that non-sarcomeric genes were associated with less frequent systolic dysfunction. So it could be useful. This should be worked on, but I have a question. Perhaps I missed the point, but do you observe as a whole that genetic forms are more worse regarding the prognosis? The fact to identify a mutation per se is associated with different prognosis or not in your cohort?
Yes, I think when you have a complex genetic complex like different component, heterozygotes component in the same patient, you have a worse prognosis. But I think we talk this a complex genotype. But we have a little variance to note the prognosis of this patient, because sometimes you can find other clinical aspect like a big scar, and you don't know if is the mutation, is the combination of this variant with other findings you can find in the patient. And sometimes this is very difficult to
okay. And of course, as you said, genetic testing should be also integrated into general genetic counseling. And we should also think about cardiac screening in the relatives, which is more basic, but not always always performed. So we can identify additional patients, of course, through a systematic cardiac screening, which is very important too. Okay. Are there some questions? No questions from the chat, I think. Jose, do you have some comments about?
Yeah. So you mentioned, Javier, that the same gene, but maybe different areas of that gene that are disrupted could be the responsible of the different phenotypes. But do you think that the expression, the phenotypic expression of these genes can also have a prognosis implication? So maybe you have a mutation in one specific gene, but the fact that having the expression being a dilated cardiomyopathy or more similar to an arrhythmogenic cardiomyopathy. So the expression of that gene can also add prognostic information about the severity of this gene, or the prognostic information is only dependent on the gene irrespectively of the phenotypic expression of that?
This is difficult because I think I don't have a lot of data to answer to this question, but I can say a personal opinion that and extrapolated this information about the information we have from other cardiomyopathies and from other genes. We know that there are regions, that there are different variants of the gene that related with a worse prognosis. I think it will be similar in this entity, but the studies and the information, the data is limited. But I suppose is this, but I don't know.
And also the typical question that we always considering. So do you think that in the future, for example, analysis of the whole genome sequencing or a multi-omic evaluation will be more valuable in the future? And specifically, if you consider that in this specific entity that there are more phenotypes that could be, as you mentioned, normal phenotypes and a true cardiomyopathy, do you think that future studies would add more information about the genetic cause of this phenotyping expression?
Yes, I think in the future with the artificial intelligence, with all the information, with a great number of patients and health population, when we know the background, the genetic background of all this population, we can do combination information about the imaging, the genetic, and we can do relationship. But I have need to the future of the technology to arrive to all this knowledge and to this. But I think the future is in this way.
And yeah, just my final question, because we are out of the time. So we are dealing, and this is a practical question, because there are also some fellows here as well in this webinar. So when we have a family that we see that there are many relatives in this family that are affected with this phenotyping, and we perform a panel that it's linked to these diseases, and we don't find any specific mutation, what is your recommendation? So what should we do after, in order to see that there is no a genetic cause behind this disease?
I think we have different problems. The first is you don't find anything because you are doing, for example, a panel test, and you have this patient, but only you are seeing a non-compactation, hypertrabeculation with other findings. I think you need to do the next step, that is for example, an exome or a genome. But sometimes you do this in the different patient, healthy and family member with the disease, you don't find anything. In these cases, my opinion is you need to know what is the transcription of this of the DNA of this patient, because sometimes you can find alteration in the proteomic part or in the MRI part of this patient, and this is the find you can do to find the alteration in the DNA. So you can find the first part an exome. If you don't find anything like tree or other parts, you can find an analysis of the transcriptome of this patient, of one patient.
Okay, I think there are no questions on the chat as well. I think we can conclude with this webinar when we have did an update about the difficult topic that is excessive trabeculation. So I would like to thank GUARD-Heart for this opportunity to explain and do this overview of the disease, and I would like to thank you, Guillem and Javier, for this great overview that you did about genetics and imaging in this interesting topic. So thank you very much.
Thank you, Jose and Philippe.
Thank you all. Thank you
for everything, and I think we had a very nice program, and it's almost within an hour, so very good. I wish you all a very good evening, and the recording will be on the website, I think, next week. So if you would like to go back to it, then it's possible within a week or something. And the next webinar will be the 29th of October. And then it's a congenital heart disease program with about frailty and congenital heart disease in the different age categories. Okay.
Thank you all.
Have a good evening, and see you later.
See you. Bye-bye.
Bye-bye.
Bye. Thank you.